So these are my relevant disclosures. I will say that pretty much everything we're going to talk about is off-label because TAVR is not approved for bicuspid valve disease and it's not been included in any of the trials, as I'll mention later. But Lou just went through this. This is the normal situation where you have three leaflets, generally of approximately equal size, each encompassing about 120 degrees of the circumference of the annulus. But the situation we're going to talk about is this, which is bicuspid disease, the most common congenital heart disease in adults. If you look, it occurs worldwide. All ethnicities, about 1.3% of the population worldwide has a bicuspid valve. The genetics of it are not really that well worked out, despite how common it is. At least one mode of transmission appears to be autosomal dominant with reduced penetrance. And what that means is it's interesting that if you have a patient with a bicuspid valve, and we have a lot of them, about 9% of those of their first-degree relatives will actually have a bicuspid valve. But importantly, a third of their first-degree relatives may have dilation of their aortic root or ascending aorta. And so you need to stress the importance of echocardiographic screening of all their first-degree relatives, not just for a bicuspid valve, but also for aortic dilation. And I remind my patients who have a bicuspid valve, well, your child may not have a bicuspid valve, but they still probably need to get an echo about every 10 years through life to make sure they don't develop dilation of the aorta, which is a pretty well-described phenomenon at this point. It also seems to be more common in males, 3 to 1, for whatever reason, again, related to that variable penetrance, and it is responsible for more deaths and complications than all other congenital heart defects combined. Lou showed you a little bit of this, but most commonly you have two cusps of equal size. As seen in the top right there, there are multiple classification systems. This is the SAVRs, which is based on the number of what are called raw phase, which are incomplete commissures like you see here. This is a SAVRs type 1 R/L, which means the right and left are fused. This is the most common, probably 85% of all bicuspid valves are SAVRs 1, and the SAVRs 1 RL is the most common at maybe 70%. This is a SAVRs 2 valve, which means it has two raw phase. Most commonly, it's left-right fusion and right non-fusion, as this is one of my patients, and it's maybe 5% or so. It's pretty equal in frequency to the what's called the true bicuspid, the SAVR 0. It's a 0 because it has no raw phase, just two equal leaflets, either an anterior, posterior, or a medial lateral distribution with 180-degree opposite to coronary arteries, which is a little different than the normal situation. So bicuspid valve disease is just fascinating to me. It's a syndrome. There's a number of associated defects. This is a patient I operated on last week who has the most common coronary anatomy you see in these patients. Frequently have very short. They'll be left dominant with the circ that goes all the way out in the groove, frequently given off a PDA, and frequently have a very short left main, maybe 10 millimeters or less. Coarctation of the aorta is associated with bicuspid valve. This is one of my patients I operated on in the past who had the SAVRs 1 R/L bicuspid valve and had a coarc that hadn't been diagnosed until adulthood, and we replaced her valve and did an ascending aorta, descending aorta bypass at the time of surgery. Also, what's called pseudocoarctation, where that descending aorta may be tortuous or just mildly narrow, but didn't develop into a true coarctation, and it's just part of the syndrome that you see. Patients with interrupted aortic arch have increased incidence of bicuspid valve. Importantly, and we'll talk a lot about it, is the associated with bicuspid valve with aortopathy. At least half of patients that have bicuspid valve have some dilation of their proximal aorta, and it's something that you need to always have in mind whenever you ever see a patient with bicuspid valve. Turner syndrome, Williams syndrome are also conditions associated with increased frequency of bicuspid valve. So what is the distribution of bicuspid versus trileaflet valves in patients undergoing AVR? Well, if you look at bicuspid valve, patients with bicuspid valve, the most common reason that they come to medical presentation or have surgeries is they develop aortic stenosis, much more common than AI, which is only about 15% of cases. And if you look at all patients under the age of 70 who are undergoing AVR, bicuspid AS is far and away the most common reason. This is the blues or purples or bicuspids. You can see, even though these are patients all undergoing AVR, and you can see in the younger age groups almost all are bicuspid, but even in the older age group, there's still a significant number of patients with bicuspid valve, and that becomes relevant when we talk about TAVRs. We'll get to a little bit later. But what about SAVR, surgical AVR for bicuspid valve? Well, most patients with a bicuspid valve who need surgery are going to be low risk, STS less than 4, likely STS less than 2. And so really most of the patients are going to or at least currently be considered for surgery rather than transcatheter replacement. But if we're going to talk about SAVR versus TAVR for bicuspid valves, I think we need to know what the real world current results for aortic valve replacement in North America are. And this is a recent paper published last year by Vino Tirani looking at the STS, Society of Thoracic Surgeons Adult Cardiac Surgery database. These are all isolated AVRs performed in North America from 2002 to 2010. It's almost 142,000 patients. And if you look at that population, 80% of people who are undergoing isolated AVR in North America currently are low risk, meaning their STS, predicted risk of mortality with surgery, is less than 40%. And if you look at the mean age in that low risk population, it's 65 years. So that tells you the vast majority of those patients are bicuspid patients, because we just showed you the distribution. People that age who get AS are going to be bicuspid. Only 6% of all patients undergoing SAVR currently are high risk, which is an STS 8 to 12. And if you look at this entire cohort of 142,000 patients, the operative mortality for all comers is 2.5%, which is lower than the predicted risk of mortality of almost 3%. And they broke it down by area, and you can see these are the intermediate risk patients and high risk patients. We're definitely getting better with surgery in these patients, but I still think you can put an X through these two, because these patients in the future are not going to get surgery. I think it's pretty clear. TAVR is going to be well better than this 5% mortality rate in the intermediate risk, and much better than 12% in high risk. I think these patients clearly are going to be better suited for TAVR. I think this is the group that you really need to focus on if you're going to talk about the usual bicuspid patient. If you look at these are 80% of all patients undergoing surgery, surgical AVR in North America currently, and most of whom are going to be bicuspid. 30-day mortality, 1.7%, which is the same as the predicted mortality. So that's going to be a hard number. Certainly, I don't think TAVR is going to beat that. I think it's going to be hard to meet it. It may meet it, but then we have to think about the long-term things, some of the things Sharif talked about. The other issue that comes up in these patients is this bicuspid aortopathy. This can be dilation anywhere from the root to the arch. At least half of patients with a bicuspid valve have some dilation of their aorta, and it increases with age. There are a number of patterns, whether it's dilation of just the root, the ascending in the arch, or just the tubular ascending. And I'm not going to get into that too much, but it does have implications for what operation you have. This is, and I think Lou touched on this, it's secondary to both genetic factors, that is, these patients have some fibrillin defects in their aorta that makes them weaker than normal, but it's also a hemodynamic, the way the flow pattern is across the bicuspid valve, that the jet stream effect can lead to dilation of either the outer curve or inner curve, depending on the orientation of the cusps. But it's thought that abnormal migration of neural crest cells is the kind of common pathway resulting in bicuspid valve disease, as well as aortopathy, also probably coarctation, erupted arch as well. But if you look at patients with bicuspid valves, all segments of their aorta are on average larger than patients with trileaflet valves, even if they're not pathologically enlarged. And that larger size does have implications for the patients who are going to get TAVR, as we'll talk about later. So what is the number, the guidelines for recommending replacement of the proximal aorta in patients with a bicuspid valve? Well, they're kind of all over the place, quite frankly. The ACCHA guidelines from 2010, which is patients with treatment of thoracic aortic disease. Really, if you're just talking about I'm not talking about valve indication patients. Patients with a bicuspid valve maybe don't need surgery for their valve, but their aorta is dilated, they're asymptomatic. The number in that guideline was 5 centimeters. The European guidelines were 55, but if you had a risk factor, rapid growth, which really doesn't happen. I mean, they always say, well, if it grows more than 5 millimeters in a year, I've never seen that. It doesn't happen. The ascending aorta does not grow 5 millimeters in a year unless it dissects. It just doesn't happen. So that's really kind of an irrelevant guideline. But the 55, but if you have a family history of dissection, if you had a coarc, other things, they would lower it to 5. STS was 50, but maybe lower if you had risk factors. When the updated valve guidelines came out in 2014, ACCHA, they contradicted the other ACCHA guideline, which was an aortic guideline, and said 55 for everybody with a bicuspid valve, not 50. And then the Canadians were, of course, in between 50 to 55, being mediators like they are. But they also did say, this is interesting, the Canadians, they recommended 50 if you could have surgery in a center where the operative mortality was less than 1% for an elective case. So this clarification just came out this year, and I think it's been helpful. It's a guidelines clarification for patients with bicuspid valve. two of the points are the same. So for patients who have a valve indication, severe AS, severe AS undergoing surgery, the number has been 4.5 centimeters or larger. We replaced the aorta. That's really not different. They still use the 55 guideline for patients who are asymptomatic, have no risk factor, so no risk of no family history of dissection, no rapid growth, etc. But then this is where they changed it. So that they did come back to the 5 centimeter number in patients who had, again, rapid growth, family history of dissection, or if the patient was low risk and the surgery could be performed in an experienced center. And what they consider low risk, I wouldn't necessarily consider low risk. Less than 4% to me seems like a high number. They didn't really specify, institutional volumes or anything. But I think personally the Canadian less than 1% is probably more realistic. This is our data. We're actually submitting this to the STS meeting next week. But this is our experience here at Duke with surgery for bicuspid aortopathy over about the last not quite 11 years. 979 proximal aortic repairs from July of 05 to May to last month. And about a third, so 374, were for patients with bicuspid valve with aortopathy. We looked at just the low-risk patients because that's what the guideline addresses. And of these 374, 327 we considered low risk, which was age less than 75 and elective procedure status. And in those 327 consecutive patients, the operative mortality, 0. No patient died in hospital at 30 days. Stroke, 0.3%. One stroke at 327, no new dialysis. 41-month mean follow-up, less than 1% proximal reoperation. I think there were 2 for endocarditis. And the overall 10-year survival is 91%. So I think it validates the recently clarified guidelines for repair and experienced centers, but I think the low-risk threshold should be less than 1%. I also think it speaks to the point that most of these patients, I think, are still going to get surgery. I mean, you've got at least half that have aortopathy, they're low risk, and they're going to die of their aortic disease if you just address the valve. What about TAVR for bicuspid valve? Well, interestingly, and I showed you a little bit of that data, if you look at patients 71 to 80 who are undergoing SAVR for AS, about 42% of them actually have a bicuspid valve. And even in the 80 to 90-year-old age group, 28% have a bicuspid valve. And we see this, it comes up in conference. You have a 90-year-old and you put up their CT scan and they have a bicuspid valve. So there's definitely a population of TAVR patients or bicuspid patients who probably going to be better treated with TAVR. And interesting, Cribier's first case in 2002, which was this antegrade first generation sapien, was actually a patient with a bicuspid valve. But there are issues for doing TAVR for bicuspids. The annulus tends to be larger, it tends to be more oval. There's a risk for, as you see here, these are 2 bicuspid patients. You see this, the opening of the valve tends to be elliptical, and there's a risk for this elliptical deployment. And I'm going to show you some data later that an elliptical valve probably does not have as good a durability as a round valve because of the changes in leaflet stresses. Also, the bicuspid valves loose show you can be very heavy calcified. They can have uneven calcification, and both those things may lead to more risk of paravalvular leak, which also has implications for long-term outcomes of these patients. I just showed you there's a very frequent instance of proximal aortic pathology. Frequently what you'll see is this a very vertical annulus, which can make positioning of the valve difficult. Further, if they have root dilation, ascending dilation, TAVR's not really addressing that. And it is interestingly in the literature, it's starting to come out more as these patients with dilated aortas who get TAVR have an increased risk of aortic dissection. I'm going to show you that data, and even late dissection. On the flip side, the larger roots make coronary obstruction probably less frequent with TAVR for bicuspids. The pure AI bicuspid currently is not really a candidate for TAVR. We don't have good devices for that. But in the future, maybe all those patients, in my experience, tend to be young and tend to have root aneurysms as well. So what about the data? Well, bicuspid valve has been exclusion criteria in every single TAVR trial to date. It's also going to be exclusion criteria in the low-risk trials that are getting ready to start. So the data is pretty limited. If you look at the registries that are out there, bicuspid valve, anywhere from maybe 2 to 6 or 7% of all cases in these registries. This is just a summary of some of the tape of some of the studies, and you're not need to look at this in detail, but the numbers tend to be small. Core valve has been the valve that's been most used most frequently in bicuspids, and frequently the large sizes, not surprisingly since the annulus tend to be big, but often 29 or 31 core valve. If you look at the procedure success rate using VARC2 criteria for TAVR, if you compare the trileaflet valve patients to the bicuspid valve patients, the success rate's a little bit lower in the bicuspids, 84%. And the most common reason that they don't have procedural success is paravalvular AI. 13% of bicuspid patients in the literature undergoing TAVR have moderate to severe AI, and if you have moderate or greater AI, that's not considered procedural success for TAVR by VARC2 criteria. And this also has some implications for survival, as we'll talk about. As I mentioned, there's an increased incidence of procedure-related dissection when you're doing TAVR for bicuspids in the literature, about 2% versus less than 0.5% in trial leaflets. And late dissections have also been reported related to these valve frames and the aorta and things. And it's likely that given that some of these patients die at home, no autopsy is done, the incidence of late dissection is probably underreported. So here's the early partner data where they looked at the long-term survival with paravalvular leak. And early on it was thought that even mild paravalvular leak led to reduced survival. I think more recent studies would suggest that's probably not the case. This is core valve high risk where none, trace, and mild really had similar survival, but moderate severe clearly impairs your long-term survival. And if you look at partner 2 data, pretty similar to this, that trace mild and none are the same, but moderate to severe definitely increases your late mortality. And if we're going to have a 13% incidence of moderate to severe AI with bicuspids, I think we need to consider whether TAVR is the right option for those patients, especially if they're lower risk. There are other concerns about TAVR for low-risk patients. If you look at patients less than 65 years old who undergo SAVR, they have about an 80% 10-year survival. And as Sharif showed you, some of that, at about 7 years, I'm going to show you this, we're starting to see some drop-off in the durability of these TAVR valves. Also, the higher pacemaker rates of concern and the PVL AI, as I talked about. Also, if you look at, and Lou mentioned this, the incidence of silent brain infarcts after TAVR is much higher than after surgical AVR, maybe up to 70 to 90% of patients undergoing TAVR. If you do diffusion-weighted MRI, you'll see evidence of microemboli to the brain versus surgery is less than 50%. And there's been a number of studies now showing that although these silent infarcts may not be clinically evident, they're clearly linked to an early onset of cognitive dysfunction and dementia. So again, if we're treating low-risk patients, I think we have to be a little bit concerned about this. This is a kind of a summary slide from that paper that was in circulation looking at outcomes. The red is SAVR and the blue is TAVR. And you can see as the risk gets lower, the lines, at least based on the data in the literature, actually cross. And I think, again, down here, I don't think we're going to see, clearly intermediate high-risk TAVR is going to beat SAVR, and I think it's the way to go. But I think as we get down here into lower risk, it's going to, I think maybe it'll be equivalent in short term, but again, I think the long term is going to be really the question. And this valve durability is the key here. It's the elephant in the room. Has been mentioned that, the second generation, look at these second generation CE paramount valves, bovine pericardial valves. We've all seen patients who've had one of these that has lasted longer than 20 years in vivo. It's not everyone, but they've been redesigned. That the stents are flexible, so they cushion the leaflets, so it reduces leaflet stress. They made the leaflets a little bit thicker, and the leaflets cut better, all which has led to better durability in these later generation devices. We don't have a lot of TAVR data because, as you know, the field is relatively immature, and the patients we've been treating so far are old and have a lot of problems, and they haven't lived long enough for us to really see the durability. But, to 5 years, partner data looks okay, but Sharif showed you some of that Euro PCR data we're really starting to see after 5, 6, 7 years a drop-off. And that, surgical experience is that really after 5 years, you can see, a valve can look good and the structural valve deterioration can come on relatively abruptly. So I really think we have a lot to learn here. The TAVR valve leaflets are made of similar material as the surgical valves, are generally glutaraldehyde treated bovine pericardium or porcine pericardium, but to get them to fit into a catheter, they have to be thinner, a quarter of a millimeter versus maybe half a millimeter. And as I showed you, the thicker leaflets have better durability than thinner leaflets. Also, the TAVR frames don't they don't deflect like a surgical frame, and so therefore the leaflets don't get cushioned. And this, I'm going to show you a little bit more about this paper, but finite element analysis shows that there's higher stresses and strains on a TAVR valve compared to a SAVR valve, and that's especially true in the presence of heavy annular calcification when you have a non-circular asymmetric stent deployment. This is just this study. This is done Georgia Tech, they have a left heart model down there that's kind of the standard for testing valves. And they did a study on that model looking at TAVR and SAVR valves with under identical loading conditions. They were both, one was a SAPIEN, one was a CE, so they're bovine-treated pericardium, this the finite element model. And what they found is that the stresses and strains and fatigue damage were higher in the TAVR valves than the SAVR valves, as you can see here. And they were really located near the commissures and the stent attachments, which is where we know that these valves fail, both surgical valves and TAVR valves. And when they put them on a simulator and run them, the TAVR valve durability is about half what you see with surgical valve, 7.8 years, which is kind of pretty remarkably similar to what we're seeing in this Euro PCR data, where we're seeing these valves start to fail. And that if the valve was not circular, if it was elliptical, which is very relevant to the bicuspid population, the durability is even worse. So pros and cons, SAVR versus TAVR and low risk. I'm just going to kind of go through the reasons why we need to take pause before we think about rolling this out to all low-risk patients, and that is the PVL risk, especially the conduction risk, the brain infarct, and the limited durability. I think those are the things that are going to have to be addressed before we're going to be able to move confidently into the low-risk population. So I'll just show you about our approach to bicuspid patients, because we do treat a number of them with TAVR. It seems like we're having an increasing population of these higher risk bicuspid patients who need something done but aren't great surgical candidates. This is the guy that we treated actually a few years ago. He was 68, prior pneumonectomy, as you can see here. Also had a VP shunt. Severe AS, class 3, was extreme risk. He was not going to get surgery with prior pneumonectomy. You can see his access was good. He had a vertical annulus, as I talked about. Had the Sievers type 1 R/L bicuspid valve with a Rafe, an elliptical opening, as is typical. And so our approach to the bicuspid patient really depends on the diameter of the LVOT slash annulus at the base of the nadir of the sinuses. If at that size it's 27 millimeters or less, or within the treatment range of, let's say, a 29 S3 or a 29 evolute, then that patient we'll treat as a trileaflet valve. We'll pre-dilate and put in the valve pretty much the same way as you would a trileaflet patient. However, for the patient as shown here, who has at that level the LVOT or base of the annulus is too big, it's too big for what we have. If you dilate that valve, the valve would not seal. In that case, we actually will take a different approach, and we'll cross the valve. We will not pre-dilate it, and we'll size to this fish mouth opening up in the leaflet. So we'll plan to land in the leaflets rather than in the annulus. And usually it's a 29 evolute is what we end up using because we're not pre-dilating and we don't want to balloon dilate to crack the leaflets. A non-balloon expandable valve tends to be favored in that area. And you can see this case, this patient had an area of 686, which is well above the 660 for a 31 core valve. So we plan to land high in this in the leaflets where the area was more in line with the 29 valve. This actually was a couple years ago, so this was a 29 core valve classic before evolute was available. You can see this is, as is frequently common in these bicuspid patients, and Lou mentioned this a little bit, frequently their non-coronary sinus is bigger and deeper. You can see the non-coronary sinus is deeper than the left and the right, but the valve, the annulus, or the valve leaflets are easily identified by all the calcium. And here the valve's starting to be deployed, and the plan will be to kind of land up here in the leaflets with maybe a level 0 or 2, high implant. And here's just the valve slowly being deployed. And again, this is a classic, so you can't recapture. But with the evolute, frequently you may start and it's a little low. You can just dial it back down and adjust it until you get it where you want it. Here's the final deployment. You can see this valve is not, it's kind of constrained there, which is common. Again, you'll see on the echo, it can be elliptical. Once it's deployed, it's well expanding. You can see not much AI, and here's the calcium. This is probably even a little lower than we would frequently do. Sometimes maybe even a little bit higher. But here's the echoes of that case. You can see this bicuspid valve, not much opening area. This is just post-implant, the 120 long axis view. And again, probably a little deeper actually than we would even want it. Maybe we want a little bit higher. But here, clearly on the short axis, you can see the elliptical shape of the valve at the level of leaflets. There was just a little bit of mild AI transvalvular, but in a patient with prior pneumonectomy, pretty good result. Just a little bit of trace mild AI there on the long axis, and that patient has done well. So just to close, SAVR versus TAVR for bicuspid. Well, bicuspid valve, very common condition. It's something we're going to continue to see. Most of these patients are low risk. Most of them have AS. They're less than 70. They're low risk. And as I showed you, the results of SAVR in that population are excellent. Until we address these durability pacemaker issues, I think that that surgery is going to remain the treatment of choice, especially for the patients with associated aortopathy. However, there exists a large cohort of patients older than 70 and even older than 80 who have bicuspid valves and are at high risk for surgery. And I think it's pretty clear TAVR can be performed safely in these patients. And I think right now, as of today, the high risk, the extreme risk patients are who should get TAVR. The intermediate risk patients, I don't know. I think it's on a case-by-case basis, but you just have to remember it's off-label. TAVR is not approved for bicuspids. We badly need randomized trials, but even the low-risk trials are getting ready to start are not. Bicuspid is an exclusion, so it's going to be a while before we have any data. But with that, I'll close and welcome any questions. Thank you.